to discuss. So here we go. There are lecture objectives here. You need to know what these tests are, how you use them, when you would use them, how to interpret them, and in some instances, the cost. I've thrown some cost figures in here, just for your viewing pleasure. The topics we're going to cover today include those. You've had some of these some of these topics before in the context of something else, and we're going to bring them into the GI section as well. So we're going to start with pancreatic function, and there's, if you look at just overarching categories of pancreatic function, whether or not you're investigating pancreatic insufficiency, like in diabetes or DKA, or in hyperosmolar non-ketotic conditions, or in the case of, which are all endocrine mediated, or in the case of cystic fibrosis, which should actually be a bullet point on its own, because it's exocrine pancreas that you're primarily dealing with here, but it's still a pancreatic insufficiency issue. Versus excess syndromes, mostly Zollinger-Ellison. It's been mentioned a couple of times. Dr. Bondurant mentioned it on Friday. These are usually due to gastrinomas in the duodenum that are producing, or pancreas, that are producing gastrin, and they're hyper secretory states. Insulinoma, of course, is another one. It's they're rare, but there's something you do have to rule out. Versus inflammatory issues, acute pancreatitis, chronic pancreatitis, and the associated pseudocysts that follow, that will follow acute pancreatitis into chronic pancreatitis. Kayla Evans mentioned pseudocyst. Do you have a good feel for what a pseudocyst is? The issue, the mechanism here is that during pancreatitis, the inflammatory part, it involves the exocrine pancreas, releases the enzymes within the exocrine pancreas cells into the local environment of the pancreas. And those enzymes do what they're supposed to do, and that is digest tissue. They digest the carbohydrates, the proteins that make up the remaining pancreatic cells, forming a necrotic region of a pancreas. When you heal from that, what's left is a cyst, and it's called a pseudocyst because it doesn't have the same pathology as a true cyst. It's due to necrosis. That's why it's called a pseudocyst. And these things are prevalent. They're quite frequent after acute pancreatitis, and in many cases, acute pancreatitis is nothing more than exacerbation of chronic pancreatitis, because most of chronic pancreatitis is due to what? I felt like Bill Murray in Stripes, you know, when he said, "That's a fact, Jack." You know, anybody not seen Stripes? Are you all communist or what? That's one of the 10 best movies of all time. Stripes. That's your reading, that's your assignment this weekend, is to watch Stripes. Anyway, let me go back to the original question. Chronic pancreatitis with exacerbations being acute pancreatitis, 90% of it is due to what? Alcoholism. The other 10% is due to
Gallstones.
kidney gallstones. Okay, there's a couple of other percent that's due to other things, but that's roughly it. Okay. And then others, pancreatic cancer and sialadenitis, which is an inflammatory process of infection. It could be autoimmune disease of the salivary glands. There are different options for testing. You know about finger stick blood sugar. Finger stick blood sugar should be, you have two types, random and fasting. If it's been over 2 hours since you ate, it's considered fasting. If I just take your finger stick now and you stopped at McDonald's on the way in, it's random. And the reason you need to know that is because a value of random versus fasting, they're different in the diagnosis of, or in the suspected diagnosis of diabetes. Okay. Glucose tolerance testing, we'll go over that. Hemoglobin A1C is an important measure. We'll talk about. It's probably the best. I got a student one time, I nailed him over the hemoglobin A1C, and I will forever remember this. I don't know, did I ever tell you about this? We had a student one time, he was dumb as a stump. And I don't say that about many students, but he was. He was the dumbest of the stumps. And what made him worse was he failed the boards. He finally passed on his 4th attempt. So anyway, this was a long time ago. Anyway, one of the problems with, and this is what I never want to hear about you, is that if I say, what is hemoglobin A1C, then I want you to go research it. I want you to go look it up. What he would do, he would go over to another faculty member and say, what's the hemoglobin A1C? All right? So, that's the wrong thing to do. Well, he came out of a room with Gary Sharp, one of my old faculty members over at OU, and I heard them talking about hemoglobin, I heard them talking about cholesterol. They were talking about cholesterol. And so, Gary asked him, well, what do we need to order to get an LDL cholesterol? And this student, he didn't know. He didn't know. You know what to order if you wanted LDL cholesterol. What would you order? A lipid panel, yeah. So, Gary went back in the room, so he comes over to me, and I'm sitting there writing in a chart or something. He said, Dr. Monero, what do you order if you want a LDL cholesterol? I said, and I heard him, I said, I'd get a hemoglobin A1C. What do you mean? Hemoglobin A1C? I said, yeah, what do you think the C stands for? It's cholesterol. So he went back over, and when Gary came out of the room, he just proudly walked up to him and said, I'd order a hemoglobin A1C. And Gary just ate his butthole. So, if you ever try to take the shortcut like that, I will get you. But I don't ever expect you to do that. So, that's the story about the hemoglobin A1C. C-peptide, we talked about the pathophysiology of the pancreas. Now, exocrine pancreas, amylase and lipase. These are your two exocrine pancreas intracellular enzymes that are present in serum. We're going to talk about liver enzymes and calcium ketones and investigation of stool. Now, gestational diabetes, let's start with gestational diabetes. You know from your OBGYN course that there is a prenatal screening somewhere around the 24th to 28th weeks. And the screening is done with a sugar drink of 50 grams. 50 grams of sugar. This can also be, you can also do this test with 10 strands of Twizzlers or eating, I think it's 25 jelly beans. That will give you the equivalent of 50 grams of sugar. You do a test, a baseline test, and then 1 hour later. For the screen, if the blood sugar is at or greater than 140 at 1 hour, then that triggers an OGTT, an oral glucose tolerance test, a full glucose tolerance test of 100 grams of sugar. And then you measure that at 0, 1, and 2 hours, and sometimes people will go out to 3 hours. If any one of these values is higher than the minimum reported there, then it's considered positive for gestational diabetes. Now, there are several risk factors for gestational diabetes that I have listed over here. Young age, previous history of gestational diabetes, these are among the two primary ones. Now, this is different. When you're investigating gestational diabetes, that's different than if you're investigating just plain old non-pregnant diabetes. Because in non-pregnant diabetes, the glucose drink is 75 grams. 75 grams. It splits the difference between the other two. And again, you're taking measurements, blood sugars, at, just finger sticks are fine, and 0, 1, and 2 hours. And again, the values are here for positivity. Now, there is a range here that is sort of pre-diabetes. We don't like to use that term pre-diabetes, but at least I don't like to use it, but that's what it is. It's as you're gaining weight, as your glucose, as your body's sensitivity to insulin and glucose metabolism is getting worse, there is a delay in your ability to use this tolerance test appropriately. Impaired glucose tolerance is the designation. You're on the way. You better be doing you better be advising your patients about weight loss, exercise, and diet, or they're going to wind up eventually with diabetes. Anytime, and this is a maximum, anytime you get a finger stick blood sugar, I don't care when you ate, I don't care what you ate, if it's above 200, you have diabetes. Okay? Any questions about that? All right. Well, here we go. It's summarized right here. How about that? I put that little thing in there. Did you see that? The little thing? I've never used that before. I found it. Okay. Monitoring diabetes with A1C. A1C, you guys, I'm sure Dr. Latassi covered A1C in her discussion of diabetes. Are you guys comfortable with A1C? The reason it correlates with approximately the last 3 months on your average blood sugar or serum blood sugar is because that's how long a red cell lives, about 3 months. So that's why it's looking at 3 months. And it's glycosylation of the hemoglobin, not cholesterol. It correlates quite nicely. If you get an A1C of 8 or 9 or 10, it correlates quite nicely with the average blood sugar over the preceding 3 months. The highest A1C I think I've ever seen is 18 point something. Do you recall one higher?
I said 18.
18, yeah. 18 is pretty high. And you've got a lot of work to do with that. And keep in mind, let me say that if somebody presents with a hemoglobin A1C of 18 or 14 here, you're talking about a blood sugar of about 380, 400. If you start them, don't start them with 500 milligrams of metformin once a day and expect that to do much. Don't give them a couple of units of insulin and expect that to do much. You got a long way to go here to get this person under control. You want to try to get A1C down below well, normal A1C is 6.5%. It says that somewhere up there, 6.5%. You want to try to get your diabetics at least at 8 or below. To try to get them down to 6.5% or below, it takes a lot of work and a very educated person. I don't think he would mind me saying it, but Vanetta has diabetes, insulin dependent. Well, it's for control, he uses insulin, but he also uses oral medication. His A1C, you mentioned it the other day, was I think about 5 or 6. But in order to do that, you understand, he has a commanding knowledge of how to manage his diabetes so that he doesn't wind up in a diabetic coma. So a lot of education is going to have to come from you guys to patients in managing this. Always understand that when you have diabetes, you always do a couple of other labs, and one of them is for lipids. Always get a fasting lipid panel, and always get a urine for protein. Send it all, not just a dipstick. It's for microproteinuria. We'll talk about this in a second. Oh, here it is right here. Right there. So you want to make sure that you monitor that. Now, there are two trains of thought here, and I probably do it wrong. When I have a new diagnosed diabetic, you're diabetic, I'm going to start you on lisinopril then, as well as the the glucose lowering agents. I'm going to start you on lisinopril then. I think the current literature says that you don't start somebody on an ACE inhibitor until you have the presence of microalbuminuria, till you start seeing the effects of diabetes on the kidney before you start them on lisinopril. That doesn't make sense to me because the proposed mechanism for lisinopril is to lower the initial increased glomerular pressure from atherosclerosis. So it's the increased pressure that does the kidney damage, and that's why you use lisinopril. Well, why would you wait until you have proteinuria to start somebody on it? It just doesn't make sense to me, but if I'm not mistaken, that is the current thinking. Somebody might want to look that up. Any questions about any of this? I set out along with my neighbor, Randy, who looks like Phil from Duck
Dynasty.
Commander? You know
Duck
Phil?
Dynasty.
Duck Dynasty, yeah. So he lives next door to us in Eufaula. And we set out 36 jug lines Saturday night. I am a redneck. Sunday morning, we wound up with 30 pounds of catfish meat. So I'm a happy person now. All right. Hyperosmolar non-ketotic diabetes. This is something you're going to see a lot come in through the emergency room. On occasion, they'll come into the office, but, well, not occasion. You'll see them in the office, too. People will come in and the glucometer that you're using will not read their blood sugar. And they usually stop at 600. When I was at Family Medicine Center, at least once a week, we'd have a person come in with fatigue and getting up at night to pee every hour. They usually don't perceive that they're drinking. They don't perceive the polydipsia, but they do the polyuria and the tiredness. And you get a blood sugar and unable to read it. You have to do a venipuncture, send that off to get an accurate reading. If it won't read it, then realize you're dealing with somebody who is already in a hyperosmolar state. Now you need to start lowering the blood sugar, and there's a protocol to do that in the office. and in the emergency room. And that protocol involves rehydrating, which is really one of the biggest problems here, rehydrating and slow reduction in the blood sugar, not to exceed 100 milligrams per deciliter per hour. If you bring down blood sugar faster than that, you wind up with cerebral edema, and that's not real good. It says here it's seen in the elderly. I actually see this more often. I don't know if it's just an Oklahoma thing, but I see this more often in middle-aged folks, 40-year-olds, 30-year-olds, 40-year-olds, that they quit taking their diabetes oral medicine. These are non-insulin dependent people. They quit taking their metformin and glyceride and everything else, and they're just way out of control. All right? The remarkable thing about this is that, at least early on, you don't have the ketonuria on the urine with this as you do with DKA. I think the highest blood sugar I've ever seen was in the 800s. I think that's the highest one I've ever seen. Anybody seen anything higher?
I've seen like a 1300.
1300?
Yeah, they're obviously gonna come up.
Yeah.
It was some type of drug abuse too.
I noticed you're drinking a gallon of water back there. Have you checked your fingerstick?
No,
Okay.
not today.
What is the deal with you people with the gallons of water? Is it an exercise thing, or is it just the goal is to drink that gallon by the end of the day?
Yeah, sometimes I
That's
drink more.
the goal? Okay.
Just a bit.
When you have a colonoscopy, you have to drink that with a stuff called Go-Lite, and you put it in the refrigerator. It tastes like sweat. It's cold sweat. You know, it's a laxative.
Gross. It's
Yeah,
a huge jug, like, it's a pretty big jug too.
I'm sorry?
It's a pretty big jug too at the end.
Yeah, it is. It's a gallon jug, and it's, you know, I love a good colonoscopy, but I tell you what, I hate that gallon of Go-Lite. Not the colonoscopy itself, it's the Demerol Versed. I think I told you that. All right, pancreatitis. If you didn't pick up on it the other day, people with pancreatitis, they look sick. They're usually emaciated, usually they're chronic alcoholics, and they don't look good anyway. They have, in addition, severe nausea related to this, and I believe Dr. Bondurant mentioned it, or Kayla mentioned it. One of the objectives for treating pancreatitis is to put the person on gut rest. So you drop an NG tube down, and you're providing them nutrition intravenously. Nothing goes down the mouth, and you're suctioning to keep even mucus from making it into, or gastric secretion from making it into the duodenum. Though the thing you have to keep in mind, you have to watch out for, is if you're sucking off all this hydrochloric acid, that you don't wind up in metabolic alkalosis. And I think somebody mentioned that the other day with gut rest. Radiating pain to back in terms of how they present, and it's the word of the day is boring. Like an ice pick or a knife boring into your abdomen, mid-abdomen to right upper quadrant, and usually go into the back. And usually they're bent over to try to relieve the pain, and they're throwing up, and it's just a mess. Okay? Acute pancreatitis, again, those are your top two. However, hypertriglyceridemia, once it gets above 1,000, this is a risk factor. Chronic hypertriglyceridemia, 10, 20 years of your triglycerides being up is a risk factor. Now, when you get a lipid panel back, when I get a lipid panel back, and it's a person in their 30s or 40s, and the cholesterol is fine, it's just the triglycerides are high. You know, there's a way to focus on the triglycerides to bring it down to avoid the possibility of pancreatitis, or you give them the option of not doing that. The point here is that an elevated triglyceride, even as high as over 1,000, does not result in an increase in the risk factor for CAD, coronary artery disease, or atherosclerosis. This is the only thing really that triglycerides caution you for. And of course, I mentioned a few minutes ago about inflammation of the salivary gland. You can have inflammation of the pancreas with autoimmune disorders as well, like Sjogren's would be a big one. Okay? And of course, infection. Infection, particularly on top of immune deficiency. Now, the clinical features of acute pancreatitis, you know, it says it right here, it's a medical emergency. And I was talking with one of the emergency ERPAs the other day during interviews. We were talking about pancreatitis. It's so bad now, at least large city, like Oklahoma City ERs, it used to be if you had pancreatitis, it was an automatic admit for gut rest and pain control. So you're on IV pain medications, you got an NG tube down, you're going to be in a hospital a few days. It's so bad now that unless you are toxic, if you just have a run-of-the-mill acute pancreatitis, they will send you home. They'll tell you not to eat anything, just drink. Not alcohol, but Gatorade, Enfamil, you know, those nutrient drinks that the elderly will frequently use. What's the other one that's real common? Ensure, yeah, Ensure. I can't believe I forgot that. Ensure. Yeah, it's lovely stuff. Yeah. They don't admit them. Out in the rural area, you will admit them. Okay? There's a huge difference between working in a hospital in a rural area versus here in town. Okay? The issue about pancreatitis is you can wind up with renal failure, hepatic failure, adult respiratory distress syndrome, ARDS, and DIC, disseminated intravascular coagulation, and shock and dead. Now, the laboratory investigation of pancreatitis starts with the enzymes, amylase and lipase. And here is a note on amylase. Within the first day of the attack, it soars. Normally it's around 50 to 100, and amylase can go up to 10,000 during that first day. And the higher, this is one of those things, the higher it is, probably the more severe it is. Because understand that amylase is an intracellular enzyme. In order to get it in the serum, you got to have that cell to die and to lyse and to release that enzyme. So the higher that enzyme goes, the serum value goes, the more cell death you're looking at. And just for your understanding, when we talk about liver-related enzymes, the same holds true there. You know, it doesn't hold true when you're talking about something like the heart and you're looking at cardiac enzymes, because the heart's a little different. Sure, troponin and CKMB will rise due to the extent of the size of the infarct. The problem, though, with the heart is where that infarct is matters. You can die from a small infarct in a bad place. Just like the brain, you can die from a small stroke in a bad place versus a larger stroke in a place you don't use very often. But when you're talking about pancreas and liver enzymes, you're not going to wind up with an arrhythmia from pancreatic cell death, specifically, right? Okay. Now, after the amylase rises, lipase will rise. And it stays elevated for a few more days than does amylase. So your acute test is amylase, longer term is lipase. Most people will order a amylase and lipase together. If somebody's coming in though with an acute abdominal pain that you're trying to rule out pancreatitis now, understand that the lipase is probably a worthless step.
Is there a reason that it takes longer?
Is there a reason? Unless it has to do with there's much more amylase in cells than lipase. So you've got to, it takes more cell destruction over a longer time to get the lipase to go up. And the amylase, you know, once it's in the, once these drugs, I mean, why do they go down? They go down because they're clear, they're metabolized. So as you're metabolizing the amylase and producing more cell destruction, that's the only thing I could come up with. Okay. Really, the serum half-life is the bottom line. Okay. Now, hypocalcemia, this is interesting, may result from precipitation of calcium soaps in the fat necrosis. So amylase and lipase in the circulation, once it gets out into your abdominal fat, it does what's called saponification. It digests the fat, turning them to soap. Nasty. That soap binds calcium and will drop serum calcium. That's why when you're dealing with, as I said in the one of the earliest slides, in terms of pancreas, monitoring pancreas, calcium. You keep an eye on serum calcium with an acute pancreatitis. Here is our abscesses here. These abscesses, as it notes, are sterile abscesses or pseudocyst versus an abscess in the skin, which is usually MRSA. Any questions?
What's meant by soap? Is it like actually?
It digests the fat. If you've ever seen, you remember in lab, that yellow fat, how it became, some of it was hard. You know, you could cut it, you could slice it and hold it. Some of it though was liquefacted, you know, liquefaction. That's what we're talking about. It becomes that. And here's another example of what happens in the subcutaneous tissue. Somebody mentioned the other day, I don't remember Bondurant or Evans, but they mentioned either Cullen's sign or Gray Turner's sign. What's happening here is since the pancreas is retroperitoneal, the majority of the pancreas is retroperitoneal. What part is intraperitoneal? Go ahead. The tail of the pancreas, actually it's kind of an unfair question. The head, the tail are intraperitoneal. The main body of the pancreas is retroperitoneal. As these enzymes get out into the retroperitoneum, they're digesting things along the way. The fat that we just talked about, and the blood vessels. You wind up with bleeding related to pancreatitis, and that's what you see here. This is just, Cullen's sign is when you have, so the pancreas sits up here, right? It's when you have this stuff extravasate out and gravity pulls it around and down in the subcutaneous tissue. Like if you get a knot on the head up here, you're going to wind up with a black eye eventually. because it's in the same plane. That's what happens here with Cullen sign. Gray Turner sign is, they're just lying down. And that's, you get the pooling of the ecchymosis by gravity. We'll talk about this later on, but you know, when you look at bruises here, there are different colors in a big bruise like that. You'll have some yellows, some greens, some black, some red. Those things all have to do with the catabolism of hemoglobin, the rate of metabolism of hemoglobin. I think we mentioned that later on. All right, so these are our mainstays up here, the first three. You want to get a CMP because you're assessing at the same time liver function, renal function, as these things can be impacted. CBC, the presence of triglycerides, and blood gases, if you have a toxic person, are all part of Ranson's criteria I'll talk about here in just a minute. Specificity and sensitivity for these different tests, they're all pretty high. Now, imaging modalities are not so great. You see here with CT, it's not so great, and then with ultrasound, it's even less. Basically, what you're trying to do here in terms of imaging is to see if the pancreas is swollen and you're ruling out the presence of stones, which is, again, a cause of some pancreatitis. All right. In looking at amylase here, there are a couple of things you need to keep in mind. One of them is in pancreatitis, you see it can elevate quite high. In inflammation of the salivary glands, it will also elevate, but it's only modestly so. And then note that there is amylase present in the bowel wall, and infarctions of the bowel wall infarctions will lead to a tiny elevation in amylase. But again, you have to get on this within the first 24 hours. There are 2 points I want to make on this. One is that the amylase in acute pancreatitis is huge in terms of its elevation. And the second is if somebody comes in complaining of, I have pain here, it started a while ago, and you are concerned about inflammation of the salivary glands or a salivary duct stone, get an amylase. There's a mumps outbreak going on right now. You guys been reading about this? Mumps outbreak, so you're going to see that. I don't think it's not in Oklahoma City. Is it in Oklahoma City? It was over in the eastern part of the state.
Some high school.
Oh, Enid.
Enid had like 20 cases.
Yeah, where did these kids, they didn't give any information about who these kids are.
It said they ranged from elementary to high school.
Are they undocumented immigrants, or they didn't say anything about that? They didn't say they were U.S. citizens. I would find it unusual for a U.S. citizen in school age to have mumps, unless they were the children of anti-vaccination people. Interesting. I have seen several cases of an inflamed salivary gland before, mostly in people with Sjogren's disease. You'll see that. One time, 1 or 2 times, there was a duct stone. If you get a X-ray of the head and turn the contrast appropriately, that little tiny stone, you can usually find it. Those are almost always radio opaque. All right, Ranson's criteria. Somebody, I think Kayla mentioned Ranson's criteria, and she mentioned that when she went online, there were several different tests that predict survivability in pancreatitis, but none of them are 100% accurate, and that's true. Ranson's criteria has been around the longest, and is something that you'll probably encounter on the boards. So, you know, I got to thinking the other day, as I was coming out of the bathroom up there, you know, you should tell the next class, anytime a speaker says, it'll probably be on the boards, because Bondurant said it several times. You know, they're right. If you wrote that down at the beginning of the year, can you imagine how many pages that would be by the end of the year? That, I bet, would be a useful little thing you could market to the next class. Or if you could come up with all of the quotes that we've said this year, you could probably con the next class into, well, anyway, you know what I mean. So Ranson's criteria starts with, at least in the acute stage, this right here. Noting the presence of LDH, which is an enzyme we'll talk about later on, lactic dehydrogenase. It's more focused with liver involvement, as well as AST. We'll talk about that here in a little bit. Base deficit you would calculate, or it would be calculated for you from an ABG. So this is a pretty sick person to start with. Glucose elevation is looking at the amount of involvement of the pancreas, because the inflammation in pancreatitis involves also the endocrine portion, although it's an exocrine-related disorder. In fact, the degree of the inflammatory process or the infection, and finally, the age is a risk factor. You take any three of those, you can say whether or not pancreatitis is likely or unlikely. And you add to those previous 6, these 5 here, and you come up with a total right here. That total predicts mortality. You understand that if you have more than 7 of those things, if a patient presents with a blood sugar of 250, a white count of 18,000, they're 65 years old, they have an increase in BUN, 100% mortality from this disorder. So that's what shocks me so much about hospitals releasing people with pancreatitis. These things right here take about 48 hours to develop. You don't know what's happening to them in 48 hours. Okay. Any questions about Ranson's criteria? Ranson's criteria is still used and is still brought up in internal medicine circles, and you should probably know that. You don't need to know the specific points. I think I would have a general idea. You do need to know its relevance in terms of making the call for pancreatitis and you know, what would constitute lethality. Chronic pancreatitis is what usually you will find in the alcoholic population. It's a simmering. I always have this feeling in my abdomen. I'm never well. It's when these things exacerbate, it turns back into acute pancreatitis. And usually what causes them to exacerbate is the alcohol. They go on a binge, and a week later, they're in the emergency room with acute pancreatitis. The other ones here, overeating, you don't really, I don't think I've ever seen that. Drug use is, I think that would probably be a bigger issue. This is not These are recreational pharmaceuticals. These are not prescribed drugs on the coast. So, the thing about this is that if somebody has chronic pancreatitis, you're not going to see the amylase that you're expecting if it was an acute form. Late complications have to do with absorption and processing of stool. They're either going to wind up with diarrhea or they're going to wind up with steatorrhea. Steatorrhea, I think somebody mentioned it just briefly the other day, is an increase in the fat content of stool. Let's take a break and then we'll come back and start talking about stool.